Let's just jump into it. I think this will be really great. I'm really excited to have you here, Linda. This is an amazing opportunity, not only to collaborate with everything we do with patients together, but really now on the education side, first and foremost. One of the things I always love about you is kind of the way that we've also met was through the Integrative Health Symposium platform. And you brought me in as a guest, and I got to see you lecture. I get to see you do what you do in terms of being part of this great community of functional health practitioners. I am so honored to be able to have you here and join this process. So, without further ado, I want to welcome everyone and thank you all for joining us today. My name is Dr. Alex Volchonok. I'm the founder of Tetrahealth Dentistry. And today we're going to be discussing one of the most important and rapidly evolving topics in healthcare. And this is the connection between oral health, airway health, sleep, facial development, and systemic wellness. This is a really, really important topic. And as biologic and integrative practitioners, we are constantly recognizing that the mouth does not function alone in a vacuum. It's not independent from the rest of the body. It plays an important role in breathing. We know that the palatal structures play an important role in the development of the nasal floor, of the airways. And what better person than an ENT specialist, a holistic ENT specialist, to join us and talk about that connection between the mouth and the ENT systems. So I'm very excited to be joined by Dr. Linda Dahl. She brings a tremendous amount of expertise and insight from the ENT and airway perspectives. She also does amazing work with infants and babies with breastfeeding and the importance of proper palatal development. And we're going to talk about how this collaboration between ENT and airway-minded dentistry really comes together. And it's going to improve airway dysfunctions earlier, have better patient outcomes, and move healthcare towards a more preventative and comprehensive care model. So, without further ado, I just want to say thank you so much to Dr. Dahl for joining us today. And please take it away from here.
Great. Thank you so much, Dr. V, Alex, for the introduction. It's really kind. And I've loved working with you and your group as well. It's made a huge impact on my practice, my patients, and it's really wonderful as a practitioner to have a group of colleagues who are kind of thinking the same way. And so the patient care is really synergistic, and I think it makes a huge difference. It seems like something really simple with practitioners communicating with each other, but it makes a huge difference in the quality of care that the patients get from us. So I'm going to share my screen. Oops, give me 1 second. And I'm going to start my little lecture. Okay. So Alex came up with this title, which I love, How Your Mouth is Shaping Your Health. So this is an ENT perspective on airway, palatal development, and breathing, with a heavy connection to what is happening in the mouth, and actually with orthodontics as well. And so just the learning objectives for this lecture are to understand how the neonatal craniofacial structure affects airway and feeding early on. And this ties back to the work I do with infants, neonates and infants in feeding and breastfeeding. And seeing how chronic nasal obstruction can impact their craniofacial growth from infants into toddlerhood and also into adolescence and adulthood. Describe how mouth breathing can contribute to maxillary narrowing, palatal arching, and retrognathia, and understanding the relationship between the palatal shape and the nasal cavity size, which a lot of people don't think about, and then recognizing the long-term structural consequences of not treating pediatric airway obstruction, and going over some multidisciplinary approaches to treatment, but also kind of seeing how a lot of these issues begin at birth and how they can continue into toddlerhood and adolescence. And then if they're not treated early enough, then they can have long-term consequences in the adult patients as well. So first of all, the airway is a dynamic developmental system where it is constantly shaping and reshaping, like all of the rest of our bodies. All the rest of the bones in our body are, the shape of the bones in our body are impacted greatly by the muscular pull. And that's so in the head and neck development, especially when babies are born, they have a certain shape, which we'll go over specifically, but that changes based on their development, and specifically the way muscles are pulling those bones. It really changes the shape and function of the way those skeletal components work together. And the tongue posture, nasal breathing, swallowing mechanics, and muscle tone can influence the skeletal growth, and it's not just a genetically predetermined fate to have a certain type of airway. And then if there's functional impairment or obstruction during early development, it can have more permanent impact on the craniofacial structure that can also later be treated. But it's just the older the patient gets, the more work and the different types of work that have to be done, and also function, shapes, form, and vice versa. So I came up with this, I guess, way of describing the head and neck anatomy in terms of the airway to one of my patients, actually kind of recently. And I used to kind of struggle to explain all of this, but this is my favorite new way of explaining it in a simplistic way. So I think of this two-story house concept. If you're thinking about just your nasal cavities, not including these maxillary sinuses or the orbits, just this section in here. So if you think about the nasal cavities and the mouth would be like the first floor of a two-story house. The nose is the top floor. So the hard palate divides the nose and the mouth. So it's like the floor between the two levels of the house. And the septum divides the nasal cavity into two spaces. And the turbinates, which are these structures that jut out from the lateral wall of the nasal cavity, I can explain them like being furniture in the room. And the goal, I guess, the regular function of the turbinates when they're functioning normally is to increase the surface area of the nasal cavities, because that lining of the nasal cavities is really the functional organ. It's not necessarily all of the structures that are in there, but the increased surface area from the turbinates allows the lining to do its job. And that it has three main functions. It humidifies, filters, and warms the air, so that by the time it gets into our lungs, and it's 4 times more easily, the oxygen is 4 times more easily absorbed into our lungs. And it also, if you're breathing through your nose, your nose is filtering out other, I guess, allergens or particles that would otherwise just go straight into your lungs. So the turbinates have a very important function. So here's my AI created picture that I'm really proud of. So if we think of, like I said, the mouth as the first floor and the nose as the second floor, divided in two sides. And then these turbinates here are furniture that take up the room. So if they get more swollen, then there's less space in the nasal cavity. But there's other ways, based on the way this architecture changes, the structure changes, that can really impact the size of the nasal cavity. So when the palate arches upwards, when it arches and narrows upwards from mouth breathing, the nasal cavity becomes smaller. And that results in having a more narrow palate. And because the floor is buckling up from underneath, the septum, the wall that divides the two sides, can kind of crumple and end up deviated. So it's just that wall doesn't have enough room, doesn't have any space because the floor is coming up, so it kind of buckles under that pressure. And then the turbinates, even if they're not enlarged, they can take up even more space in the nasal cavity. And here's an illustration of this. So here, the normal palate here, it's kind of arched, not terribly, and here's the septum. And these are just normal shaped turbinates. But when the palate is arched, you can see how that septum is buckling, and the lateral walls of the nasal cavity are also sort of full, have buckled in a little bit too. And those turbinates, they're the same size shapes. I put in both illustrations, and you can see how even if the turbinates themselves aren't enlarged, how they're just filling up that more narrow amount of space that's in the nasal cavity. So even mild allergies, for example, which can enlarge the turbinates, can cause much more nasal obstruction if a patient already has a small nasal cavity than if everything is kind of widened. And so I want to go through the neonatal cranial architecture. So this is kind of where it all begins. And this is a huge patient population that I work with, newborns. So when they're born, the ideal anatomy for a newborn is to have a wide U-shaped palate, adequate mandibular projection, even though they're all just slightly retrognathic when they're born, the ability to contact the tongue to the hard palate, coordinated suck and swallow, breathing mechanics, and the ability to breathe through the nose. Because for the first 3 months, sorry about the typo, they are obligate nasal breathers. So they're primarily and almost only breathing through their nose for the first 3 months, which is what allows them to form a seal with their mouth around the breast or the bottle and breathe and eat at the same time. So with this kind of anatomy, they're able to unhinge their jaw and latch on and form a seal so that they can create an efficient vacuum. They'll be able to stay latched on deeply because of that jaw unhinging and then effectively transfer milk. And then there's a much lower resistance in their airway. And the tongue is really the best, most powerful way to impact the shape of the palate, especially as in newborns. And because they are feeding the way they do, the movement of that tongue and the freedom of ability of the freedom of from restriction of the ability of that tongue to move has a huge impact on the shape of the palate. So early structural risk factors, and these are the huge portion of the babies that I end up seeing that end up in my office, they have more significant retrognathia, which alters the tongue position, the airway geometry, and ability to gape. And the way I kind of describe it, I don't have a good picture for it. It's kind of complicated to draw, but that I explain to the parents that when babies are born, they should have a more sort of horizontal axis to their head, more of a round shaped head, which would allow them to unhinge their jaw and open wide enough and latch on and form a seal. And when they have a different architecture, then the shape and position of the skeletal components of their head and neck can create restrictions. Specifically, the most common shape, an example of the most common head shape is when babies have a more like oblong, almost oval, vertical head shape. So instead of having a round, sort of a horizontal axis to their mouth, if this is the palate, this is the jaw, this is the tongue, everything is rotated vertically. And it's the vertical rotation of the shape of the head that causes restrictions, not just in the mouth, but in the rest of the body and in the skull base. But when they're born like that, they already have a high palate and retrognathia. And it's the jaw position, the retrognathia, that actually tethers, or vertical rotation resulting in retrognathia, that tethers the movement of the tongue. And because the palate is so far vertical, is so vertically oriented, there's an even farther distance that the tongue has to go to reach up to that palate. And then that will result in a shallow latch where they have to take a long time to feed. They swallow a lot of air. When they're trying to latch on because they can't seal, they can leak milk out of the bottle and breast, and then often have trouble gaining weight. And in the airway, the posterior tongue displacement may actually narrow the oropharyngeal airway, and they have a smaller, and because there's that smaller maxillary volume, their nasal cavities, which are already tiny, will be even smaller. And with newborns, even if they get a little bit of mucus in their nose, it really has a huge noisy impact anyway on their ability to breathe, because as I said, for the first 3 months, they're obligate nasal breathers. And the tongue, as I mentioned, is the best way, the movement and the freedom of movement of the tongue is really the best way to naturally broaden the palate. And when babies are breastfeeding more than bottle feeding, but both can be impactful, the first, however long they're doing that year, which is, if they're breastfeeding for a year or more, that's great. But they usually eat from breast or bottle for the first year. That you can really take advantage of the movement of that tongue to flatten out a palate if they're already born. And that some of the procedures I do in the office are releasing these restrictions so that the baby can do that. And if their tongue can reach up to the palate, then they'll have more normal transverse maxillary growth. And when the tongue is seated more posteriorly, it can't lift up and flatten out the palate, so it can promote more maxillary collapse, and the palate can vault up even more. And so if the tongue can't elevate, just reviewing, you get a more narrow arched palate, which means that the nasal floor is higher and the nasal airway itself narrows as well. And so functional restriction of the tongue can occur regardless of what the frenulum looks like. And I won't get into a whole conversation about tongue tie and lip tie and all those things, because that's a whole other lecture. But I view most of the oral restrictions in terms of feeding and airway for newborns as being, as having this kind of architecture really more than just frenula causing this tethering. And so if a baby is able to nurse early and breastfeed, I guess, normally, then they'll get mandibular excursion, the tongue will elevate, they strengthen their buccinators, and they have coordination of their nasal breathing. Bottle mechanics differ quite a bit, but a lot of these babies who have trouble with latching because of that anatomy also can't form a seal around a bottle, because again, the bottles are horizontal, and the baby's anatomy, when they're having difficulty, tends to be more vertically oriented. And the feeding mechanics influence their oral musculature, palatal width and growth. And sometimes it makes it even hard for them to use pacifiers, but pacifiers are interesting because I always say they're the orthodontist's enemy. But it's amazing how many parents will let their babies use pacifiers beyond 1 year. I would say year is a cutoff for the pacifier, and 2 years is a cutoff for the bottle. And if they keep those pacifiers for longer than that, then they kind of act as like thumb sucking. They're actually pushing the palate up, and it creates an even worse version of all of these kinds of upper airway obstruction than that can happen in any other way. Actually, it just pushes that palate up even higher. And then as the babies are transitioning into childhood, assuming say a baby is already born with a setback jaw and a high palate. And then when they turn, 2, then they start getting a little bit of nasal obstruction. And that can be from allergies or from their adenoids growing. Sometimes tonsils and adenoids can grow together. And if they're already born with that, retrognathia and that high palate, any amount of upper airway obstruction is going to have a greater impact on their ability to breathe through their nose, because they're already starting out with kind of a smaller nasal cavity. So in these children, I think the palate is often overlooked. And especially in my field, babies have symptoms, or children have symptoms in this age group, that will look at their adenoids and tonsils and look at the absolute size of them, not really take into account the amount of space that's in the nasal cavity. So I usually tell parents of newborns that are already born, with some obstruction, to be even more careful and watch for, chronic mouth breathing, or the hypernasality of their speech, a lot of ear infections, and fluid being trapped in their ears, because they're kind of even more sensitive to having long-term issues, even if they decide, even if the pediatrician says, "Oh, don't worry about it, it's, they'll outgrow it." And this, so this is kind of, and even in children that aren't already born with a high palate and setback jaw, say they breastfed fine and their anatomy is normal when they're born, if they develop enlarged adenoids and tonsils or nasal obstruction for any reason, then they will compensate by mouth breathing. And I remember when mouth tape first became a thing, and I was seeing a lot of kids back then, and I remember a father bringing in his son saying, "Oh, my kid mouth breathes all the time, so I just tape his mouth shut." And I was kind of scared, because when children are walking around with their mouth open, I mean, people talk about low tone and all kinds of other issues that are possible, but the predominant reason, the very main reason why children mouth breathe, is because they cannot breathe through their nose. And that may come with snoring, it may not come with snoring, but that mouth breathing and that, they're kind of like that. And then if they try to close their mouth and they kind of choke a little, and they have to open their mouth and breathe again, that's a really good indicator that there's something blocking either the front of their nose and their turbinates, or the back of their nose with adenoids. And then mouth breathing also alters the tongue posture. So it tends to be set back farther into the back of the throat. With that open mouth, walking around with an open mouth all the time, it changes the mandibular posture as well. And as I said, the muscular pull can impact the shape of the bone, so they can have changes in the shape of their mandible as well. And it also alters facial muscular tone. And so when I was doing a lot of peds, the parents would always say, oh, low tone, low tone. But the kid would be normal in every other way, like every other functional milestone. They're hitting all of those. But they just walked around with this, sort of open mouth faces. And sometimes with a lot of mouth breathing, high palate, retrognathia, they even have a hard time eating solids because they can't lift their tongue up enough to reach the palate. And so they don't really have control of moving food to the back of their throat. And these kids, when they're born, they may or may not have issues breastfeeding. Usually they do. And then sometimes when they are older and they start eating solids and they're toddlers, they continue to have these issues. And this is often diagnosed nowadays. The most popular way to diagnose this is tongue tie. But I think it's because the tongue can't reach the palate, but it's really a much more complex three-dimensional shape to the head that's making it difficult for the tongue to elevate. So even when these children undergo frenulectomies, it doesn't have the same kind of impact as it would when they're nursing, because everything is already sort of shifted enough, more, and they're not nursing, they're not using their tongues in the same way. So doing those procedures later has very mixed, sort of controversial results depending on the situation. And then these are the classic findings. When you look at the patient, they have a long face, a narrow maxilla, high palate, retrognathia, and lip incompetence. And this I'm very proud of. This was another AI picture that took a lot of iterations, but on the left, you can see sort of the normal architecture with that sort of flatter hard palate here, and then tiny adenoids, tiny tonsils, closed mouth position. And here is sort of more typical exaggerated version of what happens when a child mouth breathes for a long time. So you see how that mouth breathing results in this relative retrognathia. So this tongue position is actually farther posterior, back towards the back of the throat and the pharynx. This palate is more arched than this one, so the nasal cavity is much smaller. And then the air that could be getting through is being blocked by this big ball of tissue, in the back, these adenoids. And so you can see in this sagittal view just how much obstruction is happening. So most of the air that this child on the right is getting is through their mouth, and it's whatever can get around those tonsils in the back. And so if there is continued mouth breathing, then that the high palate elevates the nasal floor. There's that maxillary narrowing. The septum has less space over time. And so mouth breathing can beget even more mouth breathing, because the more mouth breathing there is, the smaller the nasal cavities get. And the smaller the nasal cavities, the more impact that the furniture has in the room. So if the turbinates, if later then they develop allergies or they get a cold, they have a very narrow range of, patency in their nasal cavity. So any bit of swelling can give them really terrible symptoms. And yeah, even mild soft tissue obstruction can become really clinically significant if the nasal cavity is already small when you're starting out. And so there's this vicious cycle of mouth breathing. You get nasal obstruction, mouth breathing, low tongue posture, narrow palate, smaller nasal cavity, more increased resistance, more mouth breathing, and it just kind of goes on and on. And this is you can't read any of this, but this is this mind map I created based on sort of what often happens when newborns are born with this, vertical rotation, craniofacial vertical rotation, and all of the different things it impacts and how they kind of feed back and impact each other. It's just supposed to show you how complicated this is. And early intervention is really important because when babies are small, their craniofacial bones are highly malleable. That doesn't mean that it can't be treated later, but it's easier when they're smaller because the potential for modeling decreases with age. It's different. And then the dysfunction, instead of being malleable, becomes more skeletalized. And then there's different treatments that have to be done, which Dr. Volchonok will talk about in a bit. And so with delayed treatment, they can require things like palatal expansion, which would be after their permanent teeth come in, orthodontics, myofunctional therapy, which is becoming much more popular sort of as an adjunct to dentistry. speech therapy, speech and swallow therapy, frenulum release, like I mentioned, it's controversial. Nasal surgery, where they may need septoplasty. Turbinate reduction is when they're older, meaning like in adults, and then also orthodontic surgery. And then there's a lot of different approaches that can be used on the left. And then there's all these providers that can be part of this workup. So the longer you wait, actually not necessarily, the longer you wait, the more providers are needed. Not necessarily, like a lot of these babies are already seeing like an ENT and speech therapist, a myofunctional therapist, osteopathy. They're getting all this work done early. And I think because there's so much more awareness and push towards breastfeeding, parents are much more aware of all these different treatments early on. So if they get a lot of the right kinds of support early on, then sometimes it can avoid later needing all of these treatments later. And then in adolescence, so say when I used to see kids a lot, the parents would often say, or the pediatricians would say, well, just wait, let them outgrow it. And if you let them outgrow it, then once the tonsils and adenoids, so they say they have huge tonsils and adenoids, you're like, wait till they shrink and then it doesn't matter anymore. But tonsils and adenoids start growing at age 1, and then they are supposed to peak at age 4 to 5, and then by 7 years old, they're supposed to be gone or shrink down to nothing. And during that time, potentially from age 1 to age 7, there's a lot happening, and there's a lot of development that's happening. So, and I've had a number of patients like this where I've watched everything get blocked up, and then they develop the adenoid facies and all of these structural changes, and then the tonsils and adenoids go away, and then you're left with these more permanent changes, and then they need all kinds of treatments later. But in adolescence, so say a child has been sort of compensating for that, and maybe they didn't get their tonsils and adenoids out, they already have a high palate, then in adolescence, they really start to notice more severe symptoms where they can have restless sleep, it can cause chronic fatigue, they can be diagnosed with ADHD, have exercise intolerance, difficulty concentrating, grinding their teeth, things like that. And then in adulthood, if they make it all the way without seeing any of us to fix this for them, they can end up with chronic nasal obstruction, snoring, sleep apnea, mouth breathing, air hunger, poor sleep, daytime fatigue, anxiety, reduced to breathing, reduced exercise tolerance. And like I said, all of it just because mouth breathing begets mouth breathing, it just continues to kind of develop that way. And so not in all adults, but in many adults, the airways disorders originate from developmental craniofacial remodeling during childhood. And sometimes they even get the tonsils and adenoids out and it still isn't enough because they have allergies or something else causing the obstruction. But back in the past, and I hope it's happening a lot less frequently now, I would have so many children that would come in with massive tonsil and adenoids who already had their braces on. They had braces before palate expand. So instead of removing the obstruction, their teeth were just kind of pulled together around the obstruction. So even, at that point too, it just causes a different kind of craniofacial shift. And so I think more people working with airway, like orthodontists too, are more aware of the of the upper airway obstruction and how it impacts even their ability to pull the teeth together. Because then those kids would end up with retainers forever because the teeth would keep going out of alignment because they couldn't breathe. And then other issues that can happen from airway obstruction are things like jaw pain, clicking, facial tension, headaches, neck pain, ear pressure, and fullness. And then they can wear down their teeth as well. And in adulthood, they can end up with chronic sinus disease, because narrow nasal cavities make it harder for the nose to humidify and do its job, basically. And with that smaller nasal cavity, they can have a hard time breathing, get a lot of sinus infections, chronic inflammation, and then that will make them breathe more, which will hurt their teeth, and then they can end up with poor sleep quality. So in conclusion, airway development is a lifelong structural process, and your airway continues to remodel from when you're born until you're not alive anymore. And the palate impacts both the oral cavity and the nasal structure. And if there is significant or even moderately significant nasal obstruction, it has a pretty big impact on facial growth, especially during early development. But it continues to develop as we age. And mouth breathing begets mouth breathing. Structural airway compromise in newborns and toddlers can become skeletized over time. And all of these, like feeding dysfunction, sleep disorder breathing, like dental crowding and nasal obstruction, can all be different manifestations of the same kind of obstructive developmental process. Early intervention is great. And airway isn't simply inherited, it is also developed. And then here are my references. And that's it.
Well, Linda, thank you so much for sharing this wealth of knowledge. I mean, this is such an incredible perspective of information, from your world that is, is so novel and so important for us as dental providers to know, but really as patients are becoming more and more informed. I think the interplay of what we're seeing the same patient from two different perspectives, right? You're seeing it from the ENT side, and I'm seeing it from the dental side. And really, we're looking at the same thing and we're trying to solve the same issues. And I love that your perspective is about prevention and early intervention and education of both the patients and even the families, the moms, the dads, the caregivers, to make good decisions. And it's one of the key things, especially when we talk about orthodontic recommendations for both kids and adults. We think about that long term perspective. So, I think it just shows how interconnected airway health and oral health, sleep, and systemic wellness truly are. I think another huge takeaway that I really appreciate that you shared was how this is a developmental issue. And I appreciate the effort you made with those illustrations and putting AI to good use, to kind of show the illustration of what a normal child's anatomy should look like and what it looks like when they are mouth breathing, and we're starting to see this high vaulted palate and the effect it has on the nasal structures. It is, on one hand, it's incredibly complex. You see how, the space for the turbinates get obstructed, the adenoids can start to play a role in this. And all these factors come together that really not just affect breathing, but really kind of go to the point of the patient's quality of life. And you created this great list of issues that might be coming up, that are key signs, really, really key signs to look for. And so, both dentistry and the ENT perspective have an important role in identifying these patterns before they progress into more significant health issues. So, thank you for doing all this. I would love to open up any questions if there are any questions from the audience to share. And Kim can help share some of those questions as well. And Linda, if you can answer them, that'd be great.
Yes, thank you so much. That was so informative. I really loved hearing everything you had to bring. I know I did drop a message in the chat during the presentation. If anyone has any questions, please feel free to drop those in the chat before Dr. V jumps on to his portion. But I did have a couple that came in our email from our newsletter regarding this, just a couple of people that weren't able to join. So I'll start with those. The first question was, how do we know which provider to see first, the ENT or the dentist?
They should work as a team.
Yeah.
I wish I could give a global answer for that. I mean, everyone has a different way of practicing, and I think we're lucky to have found each other because it works best if your team is synergistic. And I know, yeah, I mean, I've had patients where I might go talk to your dentist or your orthodontist, and they just have a very different perspective on things than I do, or so I don't think it matters as long as the team is connected well.
Okay, great. And then another question was just regarding, someone mentioned that they have chronic sinus congestion and they've tried everything. Their dental site is clear. So I guess they were just wondering how connected are the teeth roots and kind of what's happening with the chronic sinus congestion?
Yeah, so the main circumstance where I see the teeth impacting sinus congestion or infections is actually when that Alex and I talk about sometimes is when there's an oral antral fistula, when there's a hole, when they have a tooth pulled and then there's a space and there's an issue. But in general, whenever there an implant or is going to, if a patient's going to have an impact, they'll have the CT scan to make sure that there's enough lining of the sinuses and not going to puncture in the sinus. So that's really the main way the teeth impact the sinuses. I guess sometimes you can have a dental impaction or a really bad root infection. But most of the time, like if your teeth are fine and you're having chronic sinus issues, then it's just a very different perspective on what's happening. And I do a lot with like diet and, cleansing for yeast. And there's a lot of different types of inflammation that happen in the sinuses. And we think of, I would say like the dentistry and ENT, it's like we're in the same house. And now we can actually say it's the same house because they drew that house picture. But we're like, you're downstairs and we're upstairs and like no one's really talking. But we're downstairs too. But like, oh, it's the teeth. Don't pay attention to the teeth. It's so funny how in Western medicine, everything's divided up into these sections, but the body isn't divided up that way. We just did that. And so just like, the sinuses are aligning, your gut is aligning, it's like, so, the gut biome isn't like its own thing. Like you have a microbiome in your entire inside of your body and outside. So yeah, for sinus disease, it's like that kind of a workup.
I had a question come in. Hi, Dr. Dahl. I've been hearing about the connection between C-sections and colic, and I've seen a pattern of chiropractors being recommended to resolve colic in the holistic healthcare space. I'm curious of your perspective and knowledge on this.
So I will admit that I haven't read any of those studies, but I can comment on both. So I think that whenever there's associations, these kinds of associations can be helpful or they can be misleading. And the cause and effect, just because there's an association, it doesn't necessarily mean it's causative. And this, I will try to make it brief, but when babies are born, the way they sit in the womb is the primary determinant of the shape of their head and neck structure and the position of the mandible and the palate and the tongue, etc. But the birth method can also impact it as well. So if a baby is born by C-section, they don't go through the benefit of going through the vaginal canal. So they don't have like the skull bones are really flexible and they kind of overlap when they come through the vaginal canal and then kind of they're supposed to pop back open when the baby's born. And if they're born by C-section, that doesn't happen. So if the baby sits in a particular position, or if they had to have a C-section because of the position, that obviously will impact the head and neck developments and also the skull base. So when I was talking about that vertical rotation of the head also puts a strain on the skull base where the cranial nerves come out. And one of the cranial nerves is the vagus nerve. So yes, that can impact colic. But to jump from that and say, does C-section cause colic? You can see like how much you have to sort of think through to get to that. So I don't think of that as a causative thing because there's so many things that happen with babies and there's so many overlapping underlying causes. So it could just be an association. And yes, there are a lot of chiropractors now doing work on babies. They don't do like the cracking work. So when you think about a chiropractor touching a baby, it's scary at first, but the work that they do is really more about improving reflexes neuromuscularly. So, and in that body work space, there's also like sort of the most training is with cranial osteopaths, which are DOs, like they go to DO school, like medical school, and then they do a fellowship in cranial osteopathy. And then there's also people that like chiropractors doing, so it's not the same kind of work, but it is, the idea of it is that it's kind of releasing the cranial base nerves and helping the babies kind of like a reboot of their reflexes. And then there's craniosacral therapy. So there's a lot of body work and there's a lot of people getting into that baby feeding colic space.
Thank you. Thank you so much for that answer. I am going to go ahead and turn it over to you, Dr. V, and you can touch on the dental side of things. And then in the meantime, if anyone has any questions, please feel free to drop them in the chat and we'll do a final round of questions at the end.
Yeah, that's awesome. Linda, thank you for that. And I appreciate the insights on this. I will kind of share a few points that I thought were really, really interesting. Thinking about these kind of stages of life, and I really appreciate the way that you kind of presented the development of the airway as something that happens from the infant stage, progressing through adolescence and even in adulthood, some of the things that can be exposed. And we kind of see that a little bit on the dental side as well. We recommend, that babies have a dental exam usually around the time of the development of the first tooth, around 6 months into the process. But sometimes we will find that a baby will have a tough time latching or a tough time breastfeeding. And that can indicate some of these signs. And you kind of talked a little bit about, those issues, whether it can be that the tongue can't form the seal or the way the cranial base of the head has developed. And, we want to create the right environment, the right foundation for the development of that reflex, that response to be able to breastfeed, and then the proper development of the palate, the tongue, the lips, all those kind of things. And we kind of come back into the mix, really, I would say, by introducing the concept of early interceptive orthodontics, which is taking a look at, young children, typically between the ages of 5 and 9, and hopefully more sometimes on the earlier side. And we're just kind of seeing how the teeth are coming in, but also how the jaw bones are developing in relationship to the skull and the other anatomy. And it allows us, when we are able to see a patient at that phase, when we're able to see a child at that phase of their life, we can do a lot of corrective treatment. I think a really important concept is palatal expansion, right? Being able to help drive the expansion of the palatal formation and the teeth into the right positions. Usually, an orthodontist will wait for the eruption of the first molar tooth, the adult first molar. So usually that happens around age 6 to age 7. And if there's a need for that palatal expansion process, that's kind of the right time to do it because the palatal bones, they haven't fused yet, right? So they're still kind of elastic. And so we have the ability to improve that and to have that change. And there was unfortunately, I think what has happened to probably many, many adult patients is that at the time, this concept of early interceptive orthodontics wasn't around. And so they would first see the orthodontist around their teenage years, 12, 13, 14 years old. And sometimes that palatal development, going back to that great picture they showed, that palatal vault is so high, teeth can be crowded, the bite is open or the bite is off. And there is really no good way to fix it aside from extracting teeth, right? Which I think, what we call extraction orthodontia or the removal of a tooth to create space has probably been one of the most damaging things that orthodontists did for airway development. And, I don't want to be extremist to say that there's never an indication for that in today's times, but I would to say probably most orthodontists, and especially in our practice, we are so cognizant about trying to create space, create more real estate because that palate is that dividing bone between the first floor and second floor of that house. And if we can expand and we can build, we can do that. I'm curious from your perspective, what kind of pattern do you see any patterns or associations with patients who have had teeth removed for this type of reason, and everything kind of brought together and constricted in terms of airway health, the health of their sinuses and all of that?
Yeah, this was I think when I was younger, I was much more diplomatic and I would say, oh, let's work around this or whatever. But yeah, I mean, it's really, I have one patient in particular I'm thinking about it because I see her now, she's in her 20s and it's really, she can't breathe. I mean, it's really, yeah, if the palates are already narrow, that means it's high, it's vaulted up. And if, I'm such a proponent of palate expansion, even to the point that I'm trying to figure out, exercises that parents can do with newborns, like just, with their fingers and with sort of certain sucking techniques to help start flattening that palate out when they're first born. But yeah, if there is crowding and there's removal of the teeth, then it's not, and the teeth are being pulled together, like just to align them. It's just kind of continuing to promote that open mouth breathing, small nasal cavity. And most of the time, those patients, their teeth go out of alignment and they're constantly going back into retainers and they're needing braces again because they can't breathe through their nose.
Right, right. Yeah, and I think that connection was really kind of so eye-opening to me as I was listening to your presentation. And I think that's important, whether it's you're an adult patient, you've had this kind of process, and are experiencing issues with airway, breathing, sleep apnea, all these other comorbidities that are associated with it. I think it is really important to work, with a team of people to look at it. And I love, we sat down, several months back, and we've kind of been building this team, right? So, between your expertise on the ENT side and bringing in a myofunctional therapist and a pediatric dentist and a craniofacial orthodontist, and an osteopath into our group, we really have been trying to focus on changing the game on the way the airways are handled, and being able to intercept it early with the work you're doing with babies, I think is so immeasurable. I think you're really kind of creating an airway healthy generation, of kids and very informed mothers, which I think is amazing. And then we can step and help in the adolescence phase. And I'll speak to that final phase of adults, right? Like, so what do we do kind of after our 20s, our 20s to 30s when those palatal sutures are fully formed, right? And, we may not be able to just use a conventional palatal expander. Fortunately, today there's a technique called Marty, which exists in the craniofacial ortho world, where we can utilize mini implants to expand that suture. Because what happens is once that palate seal, when the palatal bones come together and seal, you can't just stretch them. If we try to do ortho, put in a palatal expander, you can move the teeth, but you don't move the bones, right? So essentially, to take your analogy about the furniture, we can move the furniture out of the house, but we didn't make a bigger house, right? And so what we can do now is we can utilize implants and sometimes some adjunctive treatment procedures to kind of create a stretch of that actual bone, and regain that elasticity of the palate. Now, the procedures are always better done if we can do them earlier, right? If we can intercept it in kids in 20s to 30s, that is the right time to do it. We've done it in adult patients and patients in their 50s and 60s, and there are studies of even patients older, but the efficacy is always best when there's still some of that elasticity to the bone. And so I think that combination of approach is one of the key things that was very eye-opening ever since I've kind of been working with you and been speaking to you about this. I really have looked so much differently at that concept of extracting a tooth just to close up a space or to fix crowding. It's like we really need to think about it the other way. So I just want to kind of, opine on that one a little bit. The other thing that I thought was really interesting that we talked about, was, the question that the patient brought up about the correlation between like dental pain and sinus pain and understanding if like a tooth can affect the sinus and vice versa. And we definitely have a lot of those, right? So we'll utilize a technology called the CBCT scan that we both read, right? So this is a 3D X-ray that you use to look at the sinuses, and we use it to look at the teeth and the jaw bones, and we kind of help correlate and see some things that are happening. And we both can see inflammation in the sinus if something is going on. But the very next question is figuring out, okay, what is causing that, right? Is this a problem of the sinus? Is this a problem of the teeth? Sometimes both. And if it is to the teeth part, because you spoke wonderfully about the sinus side, I'll speak about the teeth side. If there is an issue that's happening with the tooth, like a dental infection, that's stemming off the area, especially sometimes like hidden infections, like a root canal tooth that you won't know is leaking bacteria into the sinus space or into the bone. There's like an infection, there's no way to kind of feel it because there's no nerve tissue there. Well, sometimes the patient's first symptoms will actually feel like sinus symptoms, right? Congestion in the nose, like a nasal drip, and then we'll look at that scan and we'll understand those things. And the key thing that we're trying to prevent when we treat this condition, because those teeth need to be removed so that the infection can go away, is we don't want to end up with a hole between the mouth and the sinus. And so that's called an oral antral communication. And the feeling that a patient would have is like, they would drink water and water would get into the nose, right? Or they'll through the nose and they'll get like bubbles that are coming through in the mouth. And one of the key things that I've kind of found to help improve the success rate of treating those types of teeth is utilizing a biologic extraction protocol, where we really thoroughly clean out the infection after removing the tooth, including the component that goes into that sinus, repairing that area, utilizing like a collagen membrane material or a platelet-rich fiber membrane that we get from the patient's own blood to seal that area, and grafting the bone, helping the body rebuild the bone. And that has tremendously decreased the incidence and rates of this complication, right? That would happen because it's a really tough thing to deal with once a patient has it. Right. As you know, we've had to, really kind of get in there with some people to take care of it.
Yeah, and it's
So
crazy because a lot of their symptoms end up being horrible sinus infections. So their mouth is like relatively okay, but they just have the worst sinus infections, and it's usually one-sided. That's another hint. And then when I culture it, it grows the craziest things out of it, not normal sinus bacteria.
exactly, exactly. It's just like one thing kind of seeds the next, which is really kind of an important component. And it speaks, I think, to that bigger holistic, the bigger biologic picture of how interconnected everything is in the body, right? We are individual specialists, that is true. But the reality is we're working with one body, right? One immune system, right? And one common area here. And it's so important. I kind of the more I practice dentistry, the more I appreciate how important my role is in the overall health of patients. And I'm sure you've had to experience this, your whole career with the ENT world, because, if a patient cannot breathe well, right, it is such a downhill effect on so many other functions, right? Whether it's the ability to focus in school and be successful, to then being able to, exercise, be athletic, be healthy. And even in other stages of life where it affects things like sleep, all right, where patients can have a serious life-threatening condition if they're not breathing well while asleep, they're suffocating in their sleep. And we didn't talk much about that, but I did want to save the last few minutes of this thing. I wanted to kind of ask you a few questions about, that this what you see in kind of the sleep apnea patients, and if there's any recommendations you would give for patients, like who should check out these things, who should look out for these kind of signs, and what are those things that are really critical for them to look at, especially from your perspective.
Yeah, I think, well, snoring is one thing, sleep apnea is another thing, and they definitely overlap. I kind of think of snoring as the first kind of indication that sleep apnea could potentially come. Yeah, sleep apnea is so complex, and there are gender differences too. I think I found that in my female patients, it's harder to diagnose the source of the snoring, and it's harder to treat. And with males, and maybe that's just because so much of the research is done, more males snore and have sleep apnea than females. And then there's the basic things that we think about, like weight and and I guess like big tongues. I don't know, like there's like sort of things that people think about when people are snoring or have sleep apnea, but I think of it in sort of two classes. I guess there's the structural obstruction, and that obstruction can be anywhere. It can start in the nose, it can be the back of the nasopharynx and the oropharynx. It can be the jaw, the tongue position, and then it can also be the circumference of the neck. So there's all these obstructive possibilities that can be preventing the air from going in. But there's also a fatigue component. And for some people, it's really hard to find the structural obstruction because they are operating on such chronic exhaustion that as soon as they fall asleep, all of the tone in their muscles kind of relaxes. Like think, someone who's a shift worker who does overnight shifts, by the time they get to sleep, everything is just like relaxed and kind of collapses on itself. Like drinking a lot, like most people that get drunk and sleep on their back are going to snore, and that's an example of muscle tone being the causative blockage. But yeah, with snoring and sleep apnea, there's so many different levels of obstruction. Like none of us have really figured out a quick and easy way to figure out where that obstruction is. But the nasal cavity and having a clear nasal cavity is absolutely necessary to really impact sleep apnea, not just to cure it if that's possible. So if they also need dental work or orthodontic work, and like we were talking about palate expanders and oral appliances and things like that, making sure that the nasal cavity is clear is important so that they don't continue to mouth breathe and have that palate vault. And I think now I lost my train of thought. I was going to also, right. And if they're going to use a CPAP, if their nose is blocked, it's really impossible to use those devices as well. But yeah, the nasal blockage impacts sleep apnea and vice versa. So it isn't always the cause. But in order to fully treat sleep apnea, you really have to make sure that the nose is patent in the whole scope of treatment.
Yeah, I couldn't agree more. And I really, really appreciate that. Yeah, well, thank you so much for this. Kim, if there are any other questions, please feel free to kind of throw them out there. But I would like to make sure that patients who are watching this, know how to contact you, Linda, because you are so knowledgeable with what you do, not only for young babies and mothers and kids, but also some of the amazing work you do with professional voices, with people on Broadway. You are a wealth of knowledge and you help so many people out. So tell us how can people contact you? Where's your office? What's the best way to reach you?
Sure. Probably the best way is through my website. It's drlindadoll.com, like www.drlindadoll.com. And you can just look me up. I think if you look up Dr. Linda ENT, I think I'm the only one that comes up, at least in New York. Like it's easy to find me. And my office is located on 44th Street between 5th and Madison. So I'm pretty central.
Wonderful, wonderful. Well, thank you so much for that. I think that this was really a great opportunity for us to talk. I'm so thankful that you took the time to do this. And thank you to everyone who participated and listened to this. We will post this into our webinar series, so anyone who's missed this is able to still come back and learn from it. And we will be happy to share Dr. Dahl's contact information on this as well. There's a lot of practical insights here that I think you can apply, and we can use this to be a broader way of thinking about airway centered care and that link between the ENT world and the dental world. This is what it's all about, this sharing of knowledge and partnership together. So thank you so much for taking your time to be a part of this, Dr. Dahl. And I look forward to seeing everyone on future discussions and bringing more content like this to the forefront. Thank you.
Thanks for having me.
Bye bye.